Welcome to this week e-chat that will be on endotracheal intubation and a new trial which has not been published yet. It will appear in the JAMA soon. So Fabio Taccone and I are very pleased to welcome the two principal investigators, Sheila Miata, who is a very dynamic intensivist and professor of intensive care in Mumbai, India. And we also have the first investigator, Vincenzo Russotto, who is intensivist in Monza in Italy, who led the study. The trial is called the intube trial, and it was an observational study, but very interesting and conducted in many countries in the world. So, Vincenzo, why don't you tell us yourself what you did?
Thank you, and thanks for this opportunity to introduce this trial. This is a big observational study that involved more than almost 200 centers around the globe. We wanted to just take a snapshot of what happens in around the globe on a real life. So the primary aim of this study was just to see what happens after airway management in critical care patients, which are the complications more commonly observed after intubation.
Yeah.
And secondly, to see the real practice of intubation outside the randomized trial that investigated the best pre-oxygenation methods and so on. We want to see what happens in real life. And
so about 3,000 patients?
Yes, we have 2,090.
3,000, okay.
Around 2,000 patients. And yeah.
What did you find? What are the main findings?
Yeah, the primary outcome of the study was a composite outcome, which included the cardiovascular instability following intubation, and then cardiac arrest following intubation, and severe hypoxemia. And the
main results, what did you find?
Yes, that 45% of these intubation were complicated, or at least were associated with a peri-intubation event. At least one of these previously described events. But the most important finding is that the leading complication was cardiovascular collapse.
In 43%?
Yeah, approximately 43%.
Wow.
So this is probably the major findings, because probably to date, most trials focused on other complications, and probably we should reassess our agenda on hemodynamic profile.
Yeah, and then it was respiratory complications, I suppose.
Yes, we have. Then we have approximately 10% of severe hypoxemia and approximately 3% of cardiac arrest following intubation.
Okay. And it seems that a number of complications had long-term consequences,
yes,
days after intubation. I think it's an important finding, isn't it?
Yes, because we adjusted for underlying severity, and we noticed that ICU mortality was higher in patients suffering from at least one of these major events.
Why?
We don't know. Because probably, yes, we can say that these complications are meaningful, and we should further investigate which ones of these complications have a major role on these outcomes.
Isn't it that the patients who developed these complications were sicker than the others and more likely to die?
Probably yes, although we perform a sort of adjustment for underlying severity, and also after adjustment, this increased mortality persisted after correction for severity. So,
yeah, Fabio, Sheila.
Yeah, Sheila, I have a question for you, because as you said, you tried to make a snapshot, but people will be interested, of course, to know which are the patients at a higher risk to make this complication, because of course you want to prevent this complication to happen.
So this is the reason that we took only the critically ill patients. In hospital patients, we looked at patients in the ED, ICU, even in the operating room, but they had to be critically ill. So we didn't take the routine general anesthetic elective intubations for this purpose. And what we try to look at is, because people club intubations together, those in the anesthesia, in the operating room and in the ICU. But the patients in ICU, you're not only worried about the anatomically difficult airway, but you're also worried about the physiologically difficult airway, which makes the chance of complications much higher. So these were patients which started with hypoxemia, hypotension, metabolic acidosis, right ventricular failure, which further increases the physiology, or rather the pathology further increases the chance of complications. So this study perhaps highlights that, like Vincenzo has rightly said, all along when we do tracheal intubation, we're always worried about hypoxemia and looking at measures to reduce hypoxemia. And our focus has always been to improve peri-intubation oxygenation strategies. But in this high risk of patients, the incidence of hypotension is actually very high. And perhaps today, we need to look at measures to mitigate this. And what is interesting, if I may, to avoid hypotension following intubation, all along we've been giving fluid bolus. There's the intubation bundle from Professor Samir Jaber that talks about preloading with 500 ml of saline. And recently, Jans et al. From the Vanderbilt University did a multicentric style study and has actually showed no benefit with fluid loading. And the incidence of hypotension is high. So perhaps there is a role for the earlier administration electively of vasopressors. And this is what...
Well, maybe not. Yeah, when you say electively, you mean without good indications, because indeed some people recommend or consider to put all these patients on norepinephrine before intubating the trachea.
Right, exactly, Professor Jean-Louis. But this has never been studied. Now we are doing a randomized controlled trial comparing with preloading with fluid versus elective, using vasopressors, because this is really the next question that needs to be answered. How do we mitigate this hypotension? Because it is real.
Vincenzo, there were 26% of endotracheal intubations under capnography. I was a bit surprised. That's quite a high proportion, isn't it? No?
Yeah, this is also another important finding, because the secondary aim of the study was to see what happens in real life. And this is also another important findings, because after 10 years, more than 10 years of the National Audit project in UK that reported that the use of capnography was, the underuse of capnography was associated with the adverse events. We have, yes, the leading method to assess, to confirm the intubation today is auscultation of chest after intubation. This is a really surprising. For sure, we are not able to make conclusions on patients-related outcomes from this information. But
no, sure. And also 17% video laryngoscopies.
Yeah,
the number is increasing.
Yeah, this is these are the number of the first method used. In 17 patients, video laryngoscopy was the elective, let's say, method of laryngoscopy, and in most patients there was already anatomical difficulty before a laryngoscopy. So
yeah,
this is
Fabio, a last question.
Yeah, can you tell us, for example, something about the number of attempts? How many patients failed the first attempt, and how this could potentially increase the risk of corruption thereafter?
Yes, we have another finding is that first attempt success is associated with the reduced risk of complications. And we have an increased number of events with following attempts, so especially of hypoxia and cardiac arrest. So this is already known from literature, but we also confirmed this finding that we have probably focused on hemodynamics, but it is still true that the skills of the operator are also important, because You
Yep.
have to think both on hemodynamics, physiology, but also be prepared to just one attempt, and the first attempt should be successful in order to make a safe intubation.
Fantastic. Vincenzo, Sheila, thank you so much. This is really very interesting, and we are looking forward to seeing the paper published in the JAMA. We know it was presented at the SCCM meeting recently, and we will hopefully see it soon on paper or on the screen. So thank you very much, and take care. Bye-bye.
Thank you.